Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome to the Deep Dive. Today we're doing a real deep dive into two hands-on examinations that, well, they might seem fundamental, but they're absolutely crucial for doctors and surgeons, really vital in their daily practice. We're talking about the Digital Rectal Examination, the DRE, and the Digital Per Stoma Examination.
Right.
These aren't exactly headline grabbers, but the sources you share, they really reveal just how much rapid, vital insight they offer, stuff you often just can't get from other initial tests.
That's exactly right. And what's so fascinating, I think, is how these seemingly low-tech bedside procedures can give you such high-value diagnostic information, even therapeutic sometimes.
Therapeutic too, okay?
Yeah, they directly inform patient management, patient safety, in ways that, even cutting-edge imaging sometimes can't match right at that moment.
So we'll explore not just what these exams involve, but really why they're still irreplaceable tools for surgeons, right? Giving that immediate, actionable data.
Precisely. Data that shapes critical decisions, often very quickly.
Okay, let's unpack the first one then. The Digital Rectal Examination, the DRE. Our sources consistently call it a bedrock procedure in general surgery. But maybe from a clinician's view, especially a surgeon's, what makes it so indispensable?
Well, it's really remarkable how much information a skilled hand can gather just in moments.
Right.
You can think of it almost like a direct tactile window into some pretty critical anatomy down there.
Okay.
And for a surgeon, that immediate bedside insight, it's not just convenient, it can literally dictate the next steps, the next hour of a patient's care. It might avoid a costly imaging delay, maybe even an unnecessary admission sometimes.
Wow. So what kind of immediate insights are we actually talking about here? What can it pick up?
Oh, the range is pretty vast, actually. For instance, it's the absolute go-to for assessing common anorectal issues. Things like hemorrhoids, those swollen veins, or fissures, which are small tears. Even fistulae, those are abnormal tunnels, or abscesses, collections of pus. It also helps identify rectal masses or prolapse, where tissue is sort of descending, and even fecal impaction. For a surgeon in the ER, getting that kind of specific, immediate insight, it's gold.
And you mentioned rectal cancer assessment. Our sources really highlighted this part, especially for surgeons dealing with complex cases.
Absolutely crucial, yes. For a surgeon facing a suspected rectal cancer, the DRE is just fundamental.
Why specifically?
Well, it lets you palpate the tumor's exact location, its size, and critically, its fixation.
Fixation
Meaning whether it's mobile or if it's stuck, fixed to surrounding structures, that's vital information.
Yeah.
It also helps figure out its distance from the anal verge. And our sources, they highlight that something like 70% of rectal cancers are actually palpable.
70%, wow.
Yeah, so a skilled DRE gives immediate, really vital info for a surgeon planning a complex resection, choosing the best surgical approach. This isn't just about the initial diagnosis, it's really about shaping a precise surgical strategy right from the start.
That's a huge impact on planning. What about other areas? Does it tell you anything beyond the rectum itself?
Oh, definitely. Beyond the rectum, for male patients, it's key for prostate assessment. A surgeon can feel for benign prostatic hypertrophy, BPH, that common enlargement, or palpate for suspicious nodules that might suggest prostate cancer. And for pelvic floor dysfunction, it lets a surgeon assess sphincter tone, both at rest and during a squeeze. That's critical for understanding issues like incontinence or obstructed defecation.
And that helps decide treatment.
Exactly.
Yeah.
That information directly helps decide if a patient might need, say, physical therapy or maybe even surgical intervention.
And what about when a patient comes in with that sudden, really bad abdominal pain, the acute abdomen situation? How does the DRE fit into solving that urgent puzzle?
Yeah, in an acute abdomen, the DRE can quickly evaluate for pelvic tenderness. That might point towards things like appendicitis or diverticulitis, or maybe pelvic inflammatory disease, PID.
So it helps narrow things down quickly.
Very quickly. It can also detect masses down there, maybe reveal a high rectal temperature, which could suggest a perforation or even ischemia-reduced blood flow to the bowel. And critically, it checks for occult blood.
Microscopic blood, right?
Exactly, blood you can't see, which can be a big red flag for serious internal issues. It just offers these rapid clues that help a surgeon quickly sort through a pretty daunting list of possibilities.
And you mentioned bowel obstruction earlier. Does it give clues there too?
It does, yes. It helps surgeons detect impacted stool, which is one cause of obstruction. Or, conversely, finding an empty rectum can suggest the obstruction is actually higher up in the bowel.
Oh, okay.
So it gives immediate insight for the surgical team about sort of the level of the problem.
Yeah.
And that can guide whether the next step is maybe an x-ray or maybe it needs to be straight to the operating room.
So it's clearly diagnostic, but our sources also mentioned therapeutic uses, that it actually lets doctors and surgeons do something right then and there.
Exactly. That's a really important point. Beyond diagnosis, it enables manual disimpaction.
Removing impacted stool.
Yes, to relieve fecal impaction. For patients suffering from severe constipation, this can be an immediate, effective treatment.
That must be a huge relief for them.
Oh, absolutely. And it also facilitates other direct therapies, like inserting suppositories or enema tubes or applying topical treatments for various anorectal conditions. These are simple, low-cost things a doctor can do right at the bedside. Often gives immediate relief.
Makes sense. And what about its role maybe in ongoing care or prevention after the initial crisis?
Well, it's still an important part of colorectal cancer screening, especially vital in places where access to endoscopy might be limited, right? It offers a basic but effective screening method.
A first step, maybe?
Kind of, yeah. And it's also used for monitoring patients after anorectal surgery, help surgeons check on healing, maybe address any immediate post-op concerns like a fluid collection or an early infection.
Okay. Now, given how powerful and versatile it sounds, are there times when this exam shouldn't be done? For a surgeon, knowing when not to do something is just as critical, isn't it?
Absolutely. Patient safety is always paramount. And there are clear situations where the risks just outweigh the benefits.
Like what?
Well, absolute contraindications. First, patient refusal. That's non-negotiable. Consent is key.
Of course.
Also, immediately after anorectal surgery, typically within the first few days, you generally avoid it unless there's a very specific, compelling reason. Just too high a risk of disrupting the healing tissue.
Makes sense.
Severe thrombocytopenia, low platelets or coagulopathy, bleeding disorders. Those make it an absolute no-go because of the high bleeding risk.
Right.
And if you suspect an acute spinal injury, the positioning needed for the exam carries risks, so that's out too. Then you have what we call relative contraindications. Situations where the exam might still be needed, but you have to use extreme gentleness and consideration.
Okay, like what kind of situations?
Things like severe anorectal pain, maybe from an abscess or a fissure. You might still need to do it, but very carefully, maybe with pain relief. A recent heart attack is another one because the positioning can put stress on the heart. Neutropenia, a very low white blood cell count, increases infection risk. A latex allergy means you obviously need non-latex gloves. Unstable pelvic fractures also make it relative.
So the key message is?
The critical message for any clinician is never force it. Use generous lubrication, always use the smallest finger possible, and stop immediately if it causes significant pain or bleeding. Informed consent is essential throughout.
That provides a really clear picture of the DRE. Okay, let's pivot now to patients with intestinal stomas. Those who've had surgery resulting in an ileostomy or a colostomy where the bowel comes out onto the abdomen surface.
Right.
Our sources highlight the critical nature of the digital per stoma examination for these patients. What does this involve, and why is it so vital for managing this new anatomy they have?
Yeah, this exam is absolutely crucial for patients who've gone through that life-changing stoma surgery. It's all about managing their new anatomy and critically preventing serious complications.
Which is key for the surgeon, too, right? To ensure the initial surgery was successful long-term.
Exactly. Without this exam, subtle but potentially dangerous issues could easily be missed. So for diagnosis, surgeons use it to assess the stoma's viability. They check its color, its warmth, look for any bleeding.
Why is that important?
Because that can be an early sign of ischemia, meaning the tissue isn't getting enough blood flow and could actually be in danger of dying.
Okay, serious stuff.
Very serious. It's also key for identifying common problems like stenosis. That's where the stoma opening narrows, sometimes to the point where a finger can't even be inserted.
Wow.
It helps detect prolapse, where the bowel protrudes out too much, or retraction, where it pulls back in. Or a peristomal hernia, you can often feel a bulge around the stoma itself, and it helps spot mucocutaneous separation, where the bowel edge has pulled away from the skin where it was sewn. For a surgeon, these are all critical early warnings. They often allow for early intervention before things get much worse.
And you mentioned specific types of stomas, like loop stomas.
Yes, for loop stomas, where the bowel isn't completely divided, it's particularly important for checking anastomotic integrity.
The surgical connection.
Exactly. The exam is used to palpate the distal limb or the crotch where the bowel loops back. You're checking for strictures, areas of narrowing, or dehiscence where that surgical connection might be breaking down.
So it gives the surgeon direct feedback on how things are healing.
Precisely. It also plays a role in identifying bowel obstruction in stoma patients, helps assess the character of the stoma output, check for stenosis or maybe kinking higher up in the bowel.
Okay.
For cancer patients, it allows palpation for recurrence, either intraliminal or at the anastomosis near the stoma. That's vital ongoing surveillance. And sometimes, unfortunately, undigested things can cause obstruction, and this exam can find them.
Right. So similar to the DRE, does it also have immediate therapeutic uses?
It does, yeah. For colostomy patients, it helps with inserting an irrigation catheter for stoma irrigation. That's a key technique for managing bowel movements for some people. It can also be used for gentle dilatation of early fibrotic strictures. Sometimes that can help maintain the stoma's opening and prevent a complete blockage, potentially saving the patient from another surgery.
That's significant.
It is. And it's used for mucus fistula assessment too, checking the patency, the openness, and location of a mucus fistula, which is sometimes created to drain the unused part of the bowel.
Okay. And again, like the DRE, are there specific times when a per stoma examination should absolutely be avoided? What are the really key safety points here for surgeons?
Absolutely. The same safety principles apply, maybe even more so given how delicate a newly formed stoma can be.
Right.
Patient refusal, as always, absolute contraindication. And critically, this is really important immediately post-op, right after the stoma is created, usually the first 24 to 48 hours. That's a time to strictly avoid the exam, because there's a very high risk of disrupting the fresh anastomosis, the connection, or the mucocutaneous sutures holding the bowel to the skin. A surgeon has to be acutely aware of this period to prevent really serious, potentially life-threatening complications. Then you have the relative contraindications. Things like severe stoma pain or inflammation that could signal ischemia or infection needs extreme gentleness.
Okay.
Neutropenia, thrombocytopenia, coagulopathy, same risks as with DRE. Gnome fragile mucosa, maybe from radiation enteritis where the bowel tissue is damaged and very easily injured. And a suspected high anastomotic leak is another relative contraindication because you risk making the leak worse. The key message, again, for any clinician is never ever force this examination.
Right.
Use generous lubrication, the smallest finger possible, and stop immediately if there's significant pain or bleeding. These are delicate structures, and the potential for harm, if you're not careful, is really high.
So putting this all together, what does this mean for you, the listener, and maybe more specifically for the doctors and surgeons out there in clinical practice? It really seems these two exams, simple as they might sound, provide just an incredible amount of critical, immediate information.
Precisely. Yeah, if you connect it to the bigger picture, both the DRE and the per stoma exam are just incredibly powerful diagnostic tools. They empower surgeons with immediate hands-on information, often bypassing the need for immediate, maybe more costly imaging.
Right.
The DRE gives that rapid, crucial diagnostic info for all those anorectal, pelvic, prostate, colorectal issues. It directly guides the next steps, the management decisions. And it's truly essential for rectal cancer staging and, of course, therapeutic disimpaction.
And the per stoma exam.
That one is just vital for assessing the stoma's health, detecting those early complications like ischemia or stenosis, evaluating patency, managing all sorts of stoma-related issues, especially crucial for loop stomas, and just ensuring the patient's long-term well-being with their stoma.
So the key takeaway from our sources seems to be not just how useful they are, but that critical safety principle underlying both. They must be done gently, with enough lubrication, clear explanation, and, crucially, explicit patient consent.
Exactly. Respecting those contraindications prevents harm. And their enduring value really lies in that immediate clinical information they provide, information that often just isn't available through other initial tests. It gives doctors and surgeons this unique, hands-on diagnostic advantage that, no scan alone can replicate in that immediate bedside moment.
It really highlights the enduring importance of just hands-on physical examination in medicine, doesn't it?
It really does. These procedures exemplify how fundamental clinical skills remain absolutely irreplaceable for immediate bedside assessment and management. They directly influence patient outcomes, quality of life.
Yeah, this deep dive, it really reinforces that sometimes the most fundamental tools in medicine are also the most powerful. But they need skill, they need compassion, and a deep understanding of anatomy and pathology. For doctors and surgeons, these aren't just routine checks. They're really crucial diagnostic dialogues with the patient's body, offering insights no scan alone can give you right then and there.
It makes you think, doesn't it? How much invaluable clinical insight can be gathered just through careful, thoughtful examination, often way before you even order the advanced tests. These exams really exemplify the art of medicine, I think, where touch and observation give you critical, immediate answers.
So, as you reflect on this, maybe consider this provocative thought. In our increasingly tech-driven medical world, what other low-tech procedures or observations remain just as irreplaceable, just as vital for making those immediate, potentially life-affecting decisions like the DRE and the Per Stoma examination? How do we strike that balance between embracing technological advancement and preserving the enduring value of these foundational clinical skills that give us such immediate, crucial information?
It's a really important question.
Definitely something to think about. Thank you for joining us on this deep dive. We hope this has given you a shortcut to being truly well-informed about these critical medical examinations. Until next time.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.